think we'll get going and others can join us as they enter the webinar. First of all, it's a pleasure to be here to talk about how critically important the LPN is in long-term care. Thank you for joining us. I'm Chris Sundberg, Executive Director of Elder Voice Family Advocates and one of the founders. Elder Voice was brought together by family members whose parent, spouse, or other loved one was seriously harmed when they resided in a nursing home, assisted living, or other senior care facility. We learned early on how important the role of the LPN, RN, and other direct care staff are to assure quality, safe care of the resident. Understaffing and underpaying, however, has been a decades-long tactic of too many facilities to increase their profitability. It's no wonder that LPNs and others are burned out. But just know that Elder Voice will continue to advocate for adequate levels of staffing and very fair compensation. Next slide, please. In the next hour, I will discuss the work of Elder Voice Family Advocates and give you a very high-level overview of the new assisted living laws and conclude with our public policy positions that should be of interest of you. A copy of the relevant laws will be sent to all of you who are participating today, and they will be made available on our recorded session that'll be also posted. Nancy Haugen, an RN and board member of Elder Voice, will conclude with her discussion of caring with empathy. She will cover the impact of institutional language on empathic LPN care, understanding and responding to challenging behavioral expressions, such as refusal, resistance, and aggression, and understanding the family emotions. Transforming LPN roles of training, assignment, and monitoring to teaching, empowerment, and supportive guidance. I ask that you put all of your questions into the chat box, and then we'll address those at the end of the webinar. Next slide, please. We all need to remember that our elders are loved human beings. These are our value statement, and we've carefully selected every word of this. And it is respecting and protecting the human right for excellent and respectful care of all elders and vulnerable adults, and recognizing and supporting the many dedicated caregivers. We, however, have seen too many owners of long-term care. Please go back a slide. We, however, have seen too many owners of long-term care operate under a business model, not a care model. And it's important to, however, make clear there are wonderful providers out there who are doing a great job for both the residents and their staff. We're ever grateful to these excellent caregivers, and that knowing full well they've all gone through extraordinary stress these past few years. Next slide, please. This slide really exemplifies the core reason that Elder Voice Family Advocates exists. In just the few years between 2010 and 2018, there was a 562% increase in complaints, from 4,000 to 22,500. And keep in mind that only 1 in 14 cases get reported to authorities. So the actual numbers of cases are really much higher than this very sobering number here. So we ask the question, why? Next slide, please. We soon learned that unbelievably, Minnesota was the only state not to license assisted living. It's no wonder that there are so many issues without clear standards of care required for all facilities. Unfortunately, we cannot rely on the owners and managers of long term care to do what is right for the residents and staff. Too many are focused on cutting costs by understaffing, giving low pay, and minimizing other basic care standards in order to maximize their profitability. Elder Voice with AARP, Alzheimer's, Legal Aid, and Elder Justice Center accomplished what I thought was going to be an impossible task. Next slide, please. But it was the voices of our families willing to stand up and talk about the realities of living in a understaffed and under-resourced facility. And it was their courage to stand up before the legislative committees and tell their stories, talk to the media, and talk to their legislators. This was tough work. A lot of time was spent at the state capitol by our members and many others concerned about this issue, but the law was passed in 2019. As the quote here says from Ron Elwood of Legal Aid Services, without elder voice family advocates, steadfast and tenacious advocacy, we wouldn't have gotten the bill passed. And again, that was the courage of the families willing to stand up and talk about it. And I think we're going to have to be calling on the courage of our nursing staff and our direct caregivers to also further highlight the problems that you guys are all having. Please move on to the next slide. Just to give you now a really high level overview of what this law is, and some of you may be dealing with the new laws right now. It establishes a licensure system and that for both assisted living in general as well as dementia care licensing. It's eliminated the two contracts, the housing and then the contract for services, and creates a single line of accountability. Excuse me. It does not include, however, independent living, which we know is really becoming a growing care issue because of the prevalence of the folks who really probably belonged in assisted living, who are really being tried, care is being attempted in the independent care. It also requires that a conspicuous disclosure of the mandatory arbitration requirements be posted. And every 2 years, there needs to be a survey and inspection of the facilities without notice after this time. So hopefully they'll be able to keep up that every 2-year effect. Next slide, please. So the protections for the residents include the retaliation being prohibited, and that's retaliation in many different forms. And it's a prevalent fear of the residents and their families, and it constantly undermines the ability of people to communicate openly with their caregivers. Also, there's protections against arbitrary termination. There's an appeals process for termination of services, and there's a robust relocation transfer assistance and planning prior to termination of services. It also requires a 30-day notice with consent of the resident to transfer within the facility. For the staff, retaliation is also prohibited, and I'll go into a little more detail on that later. Also requires adequate staff levels and training requirements. The problem is that adequate isn't clearly defined. So this continues to be an issue that we will try to address in coming legislative sessions. Next slide, please. There are infection control plans, and unfortunately, this was not in place before the COVID pandemic, because I believe if it had been, we would be seeing far fewer deaths as a result of poor infection control. But it is in place now, and these plans need to be established and maintained. And I have to apologize, I've got a summer cold, so excuse a few coughs here and there. It also requires nurse supervision by an RN, and it requires both resident and family councils. And the facilities have to provide space and privacy. Excuse me again. And assign staff to help, but that does not mean staff manages or takes over either the resident council or the family council, but be there as a support to them as they direct. Resident grievances must be posted. There's a policy that needs to be up and obvious for everybody to view. And the resident rights include access to consumer advocacy or legal service advisors, and contact for at least 3 advocacy or legal organizations needs to be provided by each facility. Also, a contact information for the Office of Ombudsman for Long-Term Care and for the Ombudsman for Mental Health and Developmental Disabilities. They must assist getting information for Medicare and medical assistance, and accommodate all language and other communications, and they're encouraged to use plain English. Next slide, please. Currently, a Minnesota license is required of all personnel, and I want to state Minnesota because I'll mention some of our policy positions where this is becoming problematic here and there. Also, they must be competent in assessing resident needs, implementing services, and supervising staff. The unlicensed personnel must successfully complete the training and competency evaluation. They must have a demonstrated competency by successful completion of written or oral test. And temporary staff must meet the same requirements. Next slide, please. The medication management requirements are extensive and critically important. They must establish and maintain a medication management policy and procedures. That's to include how the medications are received, administered, documented, control for storage, monitoring, evaluating medication use, resolving errors, communicating to the prescriber, pharmacist, etc. Also, methods for disposing of unused medication, also requiring the residents be educated about the use of medication, and very strict policies for controlled substance that will ensure the security and accountability for management. An assessment must be conducted for every resident requesting medication management services, and they must be administered by a nurse, physician, or other licensed health practitioner authorized to administer these medications. An RN must instruct unlicensed personnel who has demonstrated ability to do these tasks. Next slide, please. Documentation of the administration of medication and the resident's record with medication name, dosage, date, and time to administer, and method of route of administration is required. Medication management of residents away from the home must be given written instructions for administering and handling the medication. Over-the-counter drugs and dietary supplements not prescribed must stay in the original container. There must be current written or electronically recorded prescription and must be renewed at least every 12 months. Verbal prescriptions must be received by a nurse or pharmacist. They must be stored in a secured locker and substantially constructed compartments and kept in the original container. No prescription of one person can be used for another person, and disposal must be done when a resident leaves or no longer on the service plan has expired, or death of the resident, and the record must be made of the disposal of those drugs. Next slide, please. Importantly, there are additional requirements for the assisted living with dementia care. Additional training is required. Staffing levels must be adequate to meet the scheduled and unscheduled needs of the residents, and specific dementia trained staff are required with at least 2 years of experience in Alzheimer's disease, dementia, gerontology, or related field. Additional services for residents with dementia include daily living assistance, education of the person with dementia and their designated representatives about transition and dementia care, resident evaluation to include interest, skills, emotional needs, physical abilities, activities, individualized activity plan, and structured unstructured activities and one-on-one activities. Next slide, please. A facility may not retaliate against a resident or employee. Retaliation taken or threatened against a resident would include termination of a contract, discrimination, prohibition of access to visitors, involuntary seclusion or withholding food, care, services, or withholding technology. Retaliation against the employee's unwarranted discharge or transfer, discipline or punishment, demotion or refusal to promote, unwarranted discrimination. Next slide, please. Staffing issues are really core to all of the lapses that we have seen in quality care. Understaffing leads to neglect in many forms, such as pressure sores, which are mentioned here too. It also leads to medication errors. It can lead to abuse issues by overworked, exhausted staff, and excessively long waits for help. Other issues include understaffing during the night and weekend shifts. The needs of these residents are ongoing, whether it's nighttime or weekends. They do not change. Often there's inadequate training, poor supervision, and poor hiring practices. And memory care understaffing has been very problematic and continues to be so. Next slide, please. And the pandemic has had a clear impact on the residents and the staff living and working in these assisted living residents. The residents themselves, nearly 50% of all the deaths in Minnesota to date have been in long-term care facilities, yet they're only 1% of the population. And over 200 residents and staff in long-term care facilities have died in the US. In Minnesota, this is much higher now. This is an old statistic, but it's well over 6,000 have died in long-term care. And we hover around the 47% range. And understaffing is a decades-long practice. There's nothing new about this problem, and it's now led to the crisis that we're seeing. The long-term care industry says there are 23,000 open positions, and a lot of facilities are reporting that at least 25% of their staff positions are unfilled. So, of course, the quality of the care plunges, and staff burnout is epidemic. Next slide, please. I just want to give you a little overview of some of the public policy positions that we have taken. We have been actively opposed to any change that would water down or permit other healthcare providers from other states to enter Minnesota and practice. And our concern is to maintain the high quality of standards that our Minnesota licensing does require. We have also successfully killed blanket immunity legislation for to give long-term care providers an excuse for their wrongdoing during the pandemic. They need to be held accountable, and we are working to make sure of that. Now, what we've supported is essential caregiver legislation. This is important. We need to do what we can to help these caregivers in these long-term care facilities do the job that they want to do. We also support increasing the reimbursement rates from government programs to the providers. However, if 90% of that increase goes to the wages, benefits, training, and additional staff, so not to the owners and investors of these places. They are doing just fine. We need to take care of the people who are doing the work. And then we support hero pay for nurses and staff of long-term care. Next slide, please. I had to pull out a couple of quotes that I think really kind of sum up why this work is so important. One is from Hubert Humphrey, who said, "The way we treat our children in the dawn of their lives and the way we treat our elderly in the twilight of their lives is a measure of the quality of a nation." And then our own board member, Dr. Elon Caspi, said, "We are all elders in training. Tomorrow, it may be you or me." Next slide, please. With that, I would like to turn this over to Nancy Haugen, who is a registered nurse and RN public health nurse in Minnesota. She earned her baccalaureate degree from the College of St. Catherine and a master's degree in mental health nursing from the University of Minnesota. For more than 25 years, Nancy has provided nursing leadership to multiple teams composed of public health nurses, registered and licensed practical nurses, and unlicensed assistive personnel. She was a public health nursing preceptor for more than 30 years and has taught nursing assessment competency for the Minnesota Department of Education. Nancy currently serves as a board member of Elder Voice Family Advocates and the Minnesota Department of Health's Assisted Living and Home Care Advisory Council. She has facilitated family councils at 2 assisted living communities. With that, Nancy, I turn it over to you.
Thank you very much, Chris. It really is an honor to join you in affirming the importance of the LPN role in long-term care. I didn't understand it very well until my aunt and my mother both received memory care. And so I have to dedicate this presentation with much gratitude to Suzette Paranto. She was an LPN that cared for both my aunt and my mother over 8 years and exemplified the very finest of empathic nursing care. Next slide, please. My presentation today comes through 2 lenses kind of bifocal lenses, progressive bifocals. You can't separate out the beginning or the end. And with that, my nursing lens talks a lot about collaboration with family members, administrators, and community healthcare providers, and the care team leadership that Chris already mentioned. In addition, it talks about the nursing assessments that are constant. They seem overwhelming. But through all of that, I have come to learn and appreciate the role of the LPN that is indeed about empathic presence. From the family member lens, entrusting a person for whom we care into the care of others is really difficult. It is hard, and it brings up many, many things and triggers lots of emotions. I call it family emotions in an egg beater. Over 5 years for my mother, we had repeated care deficiencies, even though we advocated powerfully for positive care. Of course, we then experienced retaliation. And that is what has stimulated my advocacy for empathic best practice nursing and personal care. Next. And this is the unique gift and role of the LPN, that empathic presence, because the LPN is the nurse who is most regularly present by the side of persons receiving care, respecting the dignity of those individuals and able to build long-term, close, trusting relationships with individuals, families, and personal representatives. It goes without saying that part of that role is meeting individual needs, physical needs, as noted in the care and service plan, but also psychological and emotional needs that are far more important in many instances. That empathic presence also infuses teaching, modeling, and guiding that empathic person-centered and directed care with other nurses and unlicensed caregivers. Next. So a couple of definitions. If we think about dignity, it is about lifting up the people for whom we care as worthy, honored, and esteemed. Next. That foundation allows us to care with empathy. Empathy being the ability to see with the eyes of another, to listen with the ears of another, and to feel with the heart of another. Next. And that is the foundation for meeting the psychological needs of all people, for attachment and connections to others, comfort, identity, occupation, meaning, inclusion, and love. Next. So let's put the pieces together. Empathic presence. We hear echoes from our nursing education. We can see pieces from the American Nurses Association Code of Ethics and the State Nurse Practice Act. We see what Chris has talked about in terms of state-specific regulation, client rights, statutes, and rules. And then it becomes fulfilled through you, the LPN. Next. So close your eyes for a minute and think back to nursing education. We heard that empathy is the essence of nursing. It is not another burdensome task to accomplish. It is a quality of the heart that gives passion, purpose, and power to nursing roles. Empathy transforms how nurses accomplish responsibilities. And it is what has allowed nurses over time to become most trusted among healthcare providers. Next. Codes of ethics and nurse practice acts are important as well. Provision 1 of the ANA Code of Ethics says, that the nurse practices with compassion and respect for the inherent dignity of every person. And the Minnesota Nurse Practice Act, LPN scope of practice, speaks about promoting a safe and therapeutic environment and advocating for the best interests of individuals. Next. So, can we find empathy in regulation? Well, Chris shared lots of the 2019 assisted living statute. A couple of other pieces focus on orientation, that staff need to be oriented specifically to each individual and the services to be provided. It is not one size fits all. It further states that for persons living in assisted living, the principles of person-centered planning and service delivery must be foremost, and adds for services for persons with dementia that those services must be provided in a person-centered manner that promotes resident choice, dignity, and that sustains the residents' abilities. Next. Well, there are challenges. We certainly know this. Empathic nursing can be lost in the overwhelming stress of implementing all these statutes and regulations, innumerable corporate policies, and the staffing challenges and turnover that we have seen, not just in the last 3 years, but accelerated in the last 3 years. Nursing roles are always evolving. And then there is crisis and emergency care that meets us almost every day. So where do we start? Next. If we start with knowing the person's life history, we will be able to anticipate and proactively address a range of individual needs that are listed here, not just the physical needs, but the emotional, psychological, social, occupational, cultural, and spiritual needs. I would encourage you to find out where in your communities you will find the life histories of the persons you care for, and how can you easily access that. The next few slides we are going to look at come from a series of pictures by Tom Hussey, Through the Mirror, images of elders, many with memory loss, who are looking at themselves as they were much younger, because we know that elders hold the memories of the past far more vividly than recent memories. So I would ask you to look at this picture and see what do you see? Do you see an elder person just hoping from a letter from a family member or friend? Or do you see what he sees? That young, enthusiastic person who earned a diploma or a degree and has great hopes for his future. Next. In this picture, do you see the slightly stooped gentleman stirring his coffee and preparing to enjoy it, but also thinking about his life as a professional with a career or a business? That is how he sees himself. Next, please. Well, here I am in not too many years from now. You might see me as a frail old woman needing care, getting from one place to another. I can tell you that I will always see myself as the determined nursing leader, and I will probably be telling you what best practice nursing is, even though you might dismiss that. Next. And here I would introduce you to the picture that reminds me of my mother. You might see the elder lady surrounded by remnants of the past, while she sees herself as the elegant, dignified woman, stylish in jewelry and clothing, who caregivers have said has resisted care because she didn't want her hair washed, this being within 12 hours after her beauty shop appointment. Next. So we have now taken on the chance to see, hear, and feel with the eyes, ears, and heart of another. Now we can go about transforming nursing with empathy. We'll look at the impact of language, institutional language and jargon, a deeper understanding of people's expressions, responses, and reactions that we have labeled as reluctance, resistance, refusal, or aggression. We'll look at understanding family emotions, taking a deeper dive into nursing roles, moving from training to teaching, assignment to empowerment, and monitoring to supportive guidance. And lastly, we'll look at how daily responsibilities and tasks can be built into relationship building interactions. Next, please. Dr. Caspi talks about moving from labeling to learning. Language is so important. The words we use influence and reinforce how we interpret others' emotional expressions and actions. Unfortunately, institutional language underpins institutionally expedient rather than person-centered care. The way we speak about the elders for whom we care impacts the quality of care. And we really need to ask ourselves, does our language reflect an empathic understanding and respect for people's dignity? Does it describe what we see and hear using neutral words without judgment and without labels? It's a big minefield, and it is my premise that persistent use of institutional and medical language continues to further stigmatize persons who are in need of care. Next, please. So how do we do this? How do we go from that old culture language that we hopefully would like to eliminate to a new culture of language that we want to support and incorporate? There is a balance here of profound importance, but also some humor. We use the words facility, memory care unit very freely. Would our care be different if we thought about the places where people live, assisted living, nursing homes, as their home, their community, and their neighborhood? My favorite of these is the floor. I cannot tell you how many times I heard, the nurse can't talk to you now, she's on the floor. And I have this image of the nurse lying on the floor. I want the nurse to get up off the floor and be with and among the people who need the nurse's care. I want that nurse to be of assistance. I want that nurse to help elders who need mobility care and support to get from one place to another, instead of considering that we are transporting them like commodities to where we want them to go. We use the word resident as a category. It's a catch-all, and I understand that, but it is so important to use the person's preferred name. I have read many, many electronic medical records. I can tell you that in most of them, I have no idea who the person is, because throughout the nursing notes, it says, resident did this, resident did not do that. I have to keep going back to the front page to say, is this Alvina? Is this Pete? Is this George? Please use the person's preferred name. Or there's identity by room number. Room 412 needs a blood pressure check. I don't know how you check the pressure of a room. And then there are the impersonal, dear, honey, bud, pal that say to family members, this person doesn't know the person I care for. I will tell you one lovely story. My mother moved into a new community and the culinary director introduced himself to her. He said, I am so-and-so. She perked right up. She looked at him right in the eyes and she said, and I am Mrs. Mayo. You know, that man referred to her and greeted her as Mrs. Mayo for the rest of her life. It was an amazing gift that I will never forget. When we think about people as dementia or Alzheimer's patients or clients, does that bring up something in your mind? If we change the tense a bit and we say the person is demented or mentally ill or insane, which is part of the definition in the dictionary of dementia, it brings up a lot of feelings. Perhaps we could consider an alternative that says, this is a person who's experiencing changing abilities and needs. In the appendix at the end of the presentation, there are many resources, including Teepa Snow's Gems, that talks about the changing abilities, but also gifts of those changes. And then there are the icks. We are not diabetics, epileptics, asthmatics, even though the medical community is still far from bringing themselves into current language. But as I was reminded by a person for whom I cared years ago, who said to me, Mrs. Haugen, we are not icks. We are people living with and struggling with difficult problems. How different would it be if we looked at the person, not the label? Next, please. In long-term care, things just seem to deteriorate and decline. And we use those words so freely. And yet again, these are people who are experiencing changing needs and abilities. And I would pose that there is always hope. Hope may change, but there is always hope. And then there are the catch-all categories: sundowning, wandering. My favorite, sarcastically, of these is eloping. I have no idea what that means or how we got to use it. But all of these categories are expressions of unmet human needs that we talked about earlier: attachment, comfort, and so on. And if we can look deeply into the person's life history, perhaps we can find a need that they can't express for us and meet that need that might diminish those mysterious sundowning, wandering, or eloping episodes. Refusal, reluctance, resistance to care, the three evil R's. I can think of it no other way. How would it be? We'll talk a little bit more about them in detail, but how would it be if we thought about people as maybe having difficulty hearing or understanding or processing prompts, or having difficulty participating or in accepting care, or even more importantly, and this will be on the next set of slides that I do, that the caregiver is having difficulty enlisting that person's participation. Then really judgmental words, disruptive, inappropriate, problem, whether person or family, aggressive behavior, violent, stalker, grabber, hoarder, attention seeker. All of these are behavioral responses, expressions, and reactions. And it's important that we substitute non-judgmental, neutral descriptions after considering the fears, confusion, loneliness, need for meaningful activity, and brain changes that are happening within that person. Next, please. So how do we transform our understanding of these expressions, responses, and reactions? Well, those words, resistance, reluctance, refusal, aggression, they are hardwired in long-term care language. They're judgmental labels that blame or shame a person for not complying with our expectations. But in reality, these are people who are experiencing an unmet need. They may not be able to describe it, and that need may not be what it seems to us. My mother was resisting showers in the morning. Actually, they started charging us more because it took longer time to care for her. But it wasn't what it seemed because my mother was a homemaker. In the morning, she was doing laundry and ironing and cleaning house and preparing meals. She never took a shower or a bath in the morning. She always freshened up before my dad came home for work. If we switch how we look at things, perhaps we can find solutions that don't require people and families to be charged more for care and for caregivers to be more frustrated. Or the actions may no longer fully be under the person's control. And in a little bit, we'll talk more about inept or hurried nursing or caregiving approaches. Next, please. In transforming our understanding, we need to recognize this as the nurse and caregiver's puzzle to solve. We need to think deeply about why we are seeing this expression, response, or reaction, and what is the actual need. And we need to consider the implications of trauma. Instead of asking, what is wrong with this person? We need to be asking, what has happened to this person in this person's life? Thinking about veterans or persons who have experienced abuse or other serious losses, or things we can't even understand, but also the implication of the trauma of what is happening to the person right now in the changes in their brain and in their life. Next, please. So with regard to the 3 evil R's, the timing may not fit with lifelong routines. The person may have difficulty recognizing the nurse or caregiver. Imagine being awakened every morning by a person you don't know. How could you possibly want this person to help you? Often the person is unable to clearly hear or understand, or may have difficulty processing the request or prompt. Or we may be moving on before they've had time to do that. Many of our elders may be embarrassed to need the help from strangers with intimate care, even when that stranger has been caring for them for weeks or months. And there may be long-standing or emerging fears. I think of falling or emerging fears of water that happen as memory care issues persist. Care may be rushed and hurried. We'll talk about that. And the response may no longer be within the person's ability to control due to their changing abilities related to physical needs, emotional, or neurocognitive conditions. Next, please. Adding to all of that, a few more things about aggression. At its very basic, what we think about as aggression is an effort by the person to maintain dignity, identity, security, control, affection, and purpose. The person may perceive the invasion of personal space or feels threatened by that stranger. Think about how closely a caregiver gets to a person. Needfully so, but also how scary that could be. Again, that person has unmet needs that they are unable to understand describe, or to express a solution. That may be a need for comfort, pain elimination, mobility, positioning, or sleep needs. When a person says, I need to go, it could bring up any of these, or the need for meaningful activity, or the sad absence of familiar life routines that have sustained them for years, or the need for companionship. It is heartbreaking to walk through the common area or be in the common area of an assisted living or a nursing home for hours at a time, to see staff members walk back and forth, saying nothing to the people in that room. Next, please. And now, our own contribution, and not for the better. We need to consider our nursing and caregiving approach, because when care and assistance is rushed, hurried, confusion develops and defensive responses happen. This picture of this person being forced to eat, I can tell you, I watched a neighbor of my mother's in assisted living being fed by someone, never allowed to clear his mouth when the next spoonful of food was put in. He would shake his head. He would try to get away. The person would hold his face. He would grab the person's arms. Is it no wonder we see what is happening? We need to really change our approaches. Next, please. So what can we do about this? We really need to model a new culture understanding of behavioral expressions. We need to honor the person's dignity, validate the person's experience and feelings, anticipate needs and the responses that we may receive, assist that person to calm, continually educate team members on more empathic approaches, and collaborate on those approaches. And then we need to respond immediately to judgmental language by care team members. We need to eliminate those words, the 3 evil R's and aggression. And we need to employ a problem-solving approach and collaboratively develop alternative approaches. Next, please. Dr. Zagola has a wonderful book. It's a very old book, but it's called Care That Works. And he says that when a person acts in a manner that causes concern to care providers, that person is usually responding as best possible under difficult circumstances. The person is usually unable to explain the reason for the actions or to consider alternatives. But here's the gift of the LPN, close to the people for whom the LPN cares. The LPN can initiate and partner in a problem-solving process with other team members. You will receive after this presentation an exercise that can be used in any situation. Next, please. I call it family emotions in an egg beater. I've given this presentation at some individual assisted living communities, and I always ask the question of staff, what is your biggest challenge? They hesitate. I say, no, I really want to know. And someone sheepishly raises their hand and says, working with a family. I totally understand. I worked with thousands of families as a professional. So it's important to understand family member responses because it helps to build close, trusting relationships, and it fosters improved care for individuals. I have 5 A's that we'll talk about. Next, please. First of all, there is the ache, that heartache, the dull pain. Your chest feels like there's a heavy weight on it. It's prolonged. It never goes away. Sometimes you find yourself holding your breath or crying and you don't know why. And then there is that sense of doom waiting for the next crisis. It moves to that apprehension. Is the person for whom we care being treated with empathy and dignity? Are their personal preferences being honored when we are not present? Is this person lonely or missing us? Will our next visit be pleasant or stressful? Will the person remember us? Will we feel welcomed by staff members? What new changes will we see? What new problem, however small, that we had not anticipated will present itself? And should we visit more or less often? Next. Beyond ache is anguish. Anguish is a suffering, distress, grief, or pain that is beyond sadness, and it is inconsolable. It is too deep for words. It is extreme, and often we feel afraid of losing control. And because it is so intensely personal, we keep it hidden from all but the most trusted staff members. And then there is anger. Anger at this terrible condition, loss of hopes and dreams, anger at other family members, anger at ourselves, and oh my, anger at the person for whom we care. And anger at the Supreme Being. I apologize. It is an emotional emotion. And it is easily triggered by hearing judgmental statements about the person for whom we care. The constant need to repeat the same information. Repeated deficiencies in care over time. Apathetic or defensive responses to our concerns. The blaming of care deficiencies on others, or the labeling of family or the person for whom we care as difficult or a problem. Now we put all this into the egg beater, and it's a great image for me because when you put all this stuff in an egg beater, think about it, how important it is to keep the balance as you're moving that handle and as things are speeding up. Because if you get out of balance, what happens? Things spill out all over. Most often it's the anger. And unfortunately, it attaches to people that we don't want to attach it to. We might really express our anger even in an inappropriate way to a caregiver. How unfortunate. And it is so difficult for us to clean up. And we need to beg your forgiveness. How many times I have said, I am so sorry. It often doesn't help. Next slide, please. So now with all of this new understanding, we can take this information and we can transform LPN nursing roles. We can transform training to modeling and teaching. One of my longtime nursing colleagues said to me, Nancy, remember, we train animals, we educate nurses. Training is task-oriented. It is typically focused on a technical skill, the who, what, when, and how. Modeling is different. It's person-oriented. It's teaching and demonstrating the critical components of why the task or care must be done in a certain way. I have had so many LPNs say to me, thank you, Nancy, for telling me why I need to do it this way. No one ever bothered to say that to me before. And at that point, we can also plan effective adaptations and approaches to meet individual needs and preferences. Teaching builds a relationship between the teacher and learner so that when a frustrated caregiver comes to you and says, oh, this is so horrible, she refused, he resisted, we can say, that sounds challenging. Let's do this together. I'll help you. Oh my, It's going to take some of my time, but it's so important. Or in my mom's case, let's try to figure out why this is happening yet again or again. Different perspective. Or let's think about a more thoughtful, considerate, respectful approach. And remember that every encounter we have is a modeling opportunity. Next, please. And then we can transform the nursing role of LPN assignment to empowerment. The Nurse Practice Act, LPN scope and practice in Minnesota, talks about assignment as part of the LPN role. First, that presumes that an RN has appropriately delegated those specific tasks and activities to a specific individual. When we transform assignment to empowerment, we can think about it differently. Rather than saying, caregiver A, you get all the left side of the hall today, caregiver B gets the right. Well, if we thought about it for the eyes of empowerment, perhaps we could look at the strengths of the caregivers and the needs of the people we're caring for, so that we can better match caregiver and person in need of care. Really, when we do this, it is far more efficient than we might at first consider. Empowerment demonstrates empathy for the people receiving care and our caregiving team. It trusts the caregiver to act competently on learned skills and approaches, and it is an ongoing process of two-way communication and support. It doesn't just say, here you go, and that's the end of that. Next, please. If we consider transforming monitoring to supportive guidance, we look again to the Nurse Practice Act. Here are the words attached to monitor or to the Nurse Practice Act regarding monitoring: inspection, watching, checking and tracking, involving a supervisor. If you look at the picture on the right, I don't know about you, but I don't want to be that person in blue sitting next to that person in white under those circumstances, because too often monitoring becomes used as a corrective or punitive process. I heard this many times when I raised concerns. Well, we'll write them up. That's not what I wanted. I didn't want people to be punished. I wanted people to be taught new and more effective ways of helping my mother have a good quality of life. Too often, monitoring becomes used to motivate by intimidation, and it is used to blame and shame, sometimes publicly, both the staff members for mistakes and errors and the person or family member for raising concerns. For example, at stand-up, a nurse said to the group, Nancy called to complain about. I need to know who did this. Well, who would own up to that and talk about throwing a family member under the bus? Wow, not a comfortable position for anyone, and it really broke trust with the family and the direct caregivers. Next, please. So if we want to really transform monitoring to supportive guidance, we need to look at the LPN's close and creative presence to identify individual needs and refresh caregiver competency and approach. Providing guidance in private, partnering with caregivers, making expectations clear, checking for understanding, offering ongoing assistance, and actually following up. Next, please. So now, the last A in the egg beater, appreciation. Families have deep appreciation for nurses who model transforming daily responsibilities with empathy. Next. In all of the slides that we have presented, I want you to know that you are free to use any of them in your teaching. We only ask that you credit Elder Voice as the source. We talked about personal preferences. but it's so important to incorporate individual lifestyle preferences into the life of the community rather than expecting the person to adapt to the routine of the facility. Important to learn and incorporate the person's life histories, and then creative presence. I can't tell you how much you can learn by hanging out with the people you care for during meals, activities, and non-scheduled times. It's a very creative way, but effective way for nursing rounds to occur. Next, communication, talking with individuals more often than when providing care, talking about the things that are important to them, speaking from a position where they can see who is talking with them, use a clear animated voice to help mitigate impaired attention and hearing, and learn and use the person's own expressions. Compliment often about anything. It will be new and wonderful to people each time it is heard. Touch as accepted. There's lots of specifics there, but the importance is that quiet, firm touch builds long-term and enduring relationships over time, and it helps to ground people. Next, accommodation. Make use of the person's long-term memory instead of what has happened yesterday. Provide meaningful and consistent cues, reduce distractions, and attend to the nonverbal responses. Avoid the things that will never work, correcting the person, or arguing or attempting to convince. It is a sad thing to say that I used this with my mother way too many times. And it took a long time for me to try and learn to adapt in different ways. Offer choices appropriate for almost every situation. When possible, pair words with actual objects, but keep the choices simple. This or that. And then meaningful activities. Please engage our loved one. It doesn't take very long for a caregiver to come to my mother and say to her, Elvina, would you help fold these towels? My mother was the best folder in the world. I loved when I could see her doing that rather than sitting with her arms in her lap with her eyes closed. And please avoid using the TV as a default caregiver. Next. Here are the tougher ones. Adapting approaches. Most importantly, using a relationship approach rather than a task-focused approach. Instead of saying, Elvina, it's time for your shower. Elvina, oh, you look so beautiful today. How about if we freshen up so that you'll be ready when Nancy comes for a visit? Oh, Nancy's coming? Well, off Elvina goes. Pause a moment for permission for that person to recognize and process. Invite instead of directing. Let's try this, or please help me. Hold the soap, do whatever. Offer assistance rather than taking over. And when all else fails and you're fumbling around, use self-focused humor in challenging situations. Oh my, oh Pete, I am so clumsy today. I am so sorry. But of course, the humor is always at ourselves, never directed at the person we are caring for. Now, really tough. Accountability, being proactively transparent about mistakes and errors, informing the family honestly and quickly, and importantly, offering suggestions to prevent future events builds trust. And then advocacy. We need to model new culture, non-judgmental behaviors and language, and we need to remove and advocate for removal of all judgmental language among all of the people that we work with from all electronic systems and in all communication with family and community healthcare providers. Next. I have been told empathy cannot be taught. You either have it or you don't. I don't believe that. Stephen Covey, in his book, The Speed of Trust, talks about a simple paradigm that we have done today. First of all, see, which is a paradigm shift, understand with empathy, speak, the language shift, communicate with empathy and remove judgmental language, and behave, the behavioral shift, model languages and approaches and care with empathy. Sometimes we can't start from the see, the understanding part. We need to expect people to behave in an empathic way, and the ability to understand and communicate will occur over time. Next, please. The last point is the minefield of moral distress. When care provided and observed does not meet or violates professional ethical standards, what do? There is a cost of speaking out, both as a minority healthcare professional in a hospitality regarding assisted living business, or when concerns are interpreted as a challenge to leadership. There is a cost, but there is a cost of not speaking out. It is the loss of trust with families and individuals for whom we care. It is increased risk of abuse and neglect. And it is the personal, mental, and physical toll that I believe is part of the turnover and the challenge of keeping staff. Next, please. Finally, thank you so much for everything you do to be a model and an advocate of empathic nursing for all you serve. We can move on now to a time for questions. I'll turn it back to Chris.
Thank you so much, Nancy. Outstanding job. I always learn more every time I hear you talk about this issue. I would remind folks, use the chat box if you have any questions. We'd be happy to address them. And if something occurs to you later, feel free to contact us. And we'd be happy to get back and discuss whatever you need. One thing, as I wait to see if anybody has any other questions, I'd like to make you aware that on August 4th, we're going to have another presenter who's going to take another lens to this personal preferences issue that Nancy talked about. And that is Dr. Mark Cohen, whose recent research has, probably not a surprising fact, but has uncovered that care preferences are largely ignored if that person is of some racial category or demographic, income category, or some other demographics. I think this will be of interest to a lot of folks, and we'll get you more information about that. I'm not seeing any questions in our chat. Okay, here comes one. What are some existing supports outside of healthcare facilities that LPNs can lean on if retaliation or fear of job security are a concern? Nancy, do you want to address this? I can too, whatever. Go for it, Nancy.
I will say that most importantly is your process in keeping information, making sure you have documented and kept copies of every piece of information that comes to you from the administration, asking to have things put in writing, making sure that they say to you in a written format, this is what we expect. this is what the concern is, and that you can respond in writing as well. So they can't say you did this when you didn't. You will have more, I'm sure, Chris.
Yeah, I would just point out that, again, it's against the law that's now put in place. So if that's happening, I would be contacting the Office of Office of Health Facilities Complaints within the Department of Health, or call us and we'll help you with that process as well. A continued question here: what can we do to continue the development of legislation to protect residents, families, and workers? Number one, this is a good time to ask that question, because we're in the election season now. You're going to start seeing your state senator and representative coming to your doors, and those who are running for that office. First thing is, ask them what their position is. Will they support adequate funding for long-term care oversight and adequate funding for reimbursement rates, and to really ensure that the staff of long-term care are being given a livable wage. And after that, there's also the governor's race. Take a very close. We've got two very distinct candidates. One who's actually got a questionable track record of support for the care of elders, and through our own experience when he was a senator, was very disappointing at that. So take a look at their backgrounds, and we'd be happy to talk individually to anybody about that as well. And then when legislative session, if we reach out to you and ask for your help, do your best to see what you can do for us. Thank you for that. Seeing no other questions, I thank you all for your participation today, and I say goodbye, and hope to see you again on August 4th for the next webinar. Thank you.
Thank you.